All right, take two. All right, well, I want to thank everybody for coming to our ORCOR Fall webinar. We're really excited today to be giving, I think, a really comprehensive thought process in terms of how to advance health and research equity. I'm so delighted to have my ORCOR steering committee colleague, Dr. Monica Parker, to be moderating this webinar. She's also going to introduce the rest of our panelists. But just to briefly introduce Monica, she's a graduate of Fisk University and University of Nebraska Medical Center. After she completed her family medicine residency at University of Mississippi, she then went to Emory, began her career as a geriatric medicine primary care provider, but then transitioned to continue to wear that hat, but also be a clinical research investigator. She is now the director of both the Minority Engagement and Outreach Corps at the Emory University Alzheimer's Disease Research Center. And we're so delighted to have a well-recognized co-investigator colleague who's made a number of contributions to the field of Alzheimer's disease research, particularly recruitment for health disparities. Monica, I'll let you take it from here. And so glad to have you and your panelists to talk about this very important topic on how to achieve health and research equity and increase underrepresented participation in our Alzheimer's disease research studies.
Thank you, Sophia, and thank you to everybody who's registered for our conference. We're happy to have you, and hopefully we'll learn something new and get a different perspective. I want to begin by saying that one of the things that is important for achieving greater equity in terms of health, but also greater representation by different minority groups is continued outreach and engagement, not only of the individuals who may be likely participants in our research, but of the medical providers and institutions that provide the healthcare to these people. Too often, I think we look for sources and people who can be trusted individuals for research, and the people that are most trusted are the people who provide healthcare to the populations we may be targeting for our different Alzheimer's research. With respect to the study that we have recently are undergoing, continue to undergo, we wanted to understand better how healthcare providers and healthcare organizations are interacting with our Alzheimer's disease research centers. From those persons who've completed the survey, and if you haven't yet done so, please send your survey in and complete same. We've learned that about more than 53% of our Alzheimer's disease research centers do get underrepresented persons from clinical practices associated with the ADRC. We also get people who are outside of our healthcare practices working in the community and community-based healthcare organizations. More than 40% of you answering the survey indicated that you do get referrals from people outside of your academic setting. Places that are resources for likely research participants include things like the Council of Aging, but also people who are part of a healthcare network that it may be outside of our academic networks or research networks. Things that you've indicated so far on the survey that you are interested in learning and getting information for are more about how we can outreach to and engage physicians and healthcare providers that are serving predominantly minority communities. More than 73% of the people submitting the survey indicated that was a need. People also continue to express a need for people who, not people, but for resources that are culturally specific for a specific demographic. And finally, one of the things that seems to be a real need, and as we move along and learn more and more about technology, there's a great need to develop technologic and informatics-based resources about how we can better access populations that may be considered hard to reach. And some of that technology has to be integrated into our healthcare electronic record and healthcare systems. Not only on mobile apps and other things. My finding is that you can't access a mobile app if you don't know it. And I'm one of the dinosaurs, as one of my colleagues likes to say, when it comes to certain types of technology, but integrating resources that inform about research opportunities into the healthcare record and making it more accessible, not only for providers to share with their patients, would be a better mechanism for doing this. Another suggestion or concern or query on the survey was how much ORCOR faculty FTA is dedicated to doing this. I happen to be somebody who occupies a rather unique position because I'm a full-time FTE, if you will, as a physician who is leveraging my patient population, social connections, and professional networks to engage people in clinical research. And that's something that I think that all of us can do. We just maybe haven't always thought of it that way. So I'm particularly delighted to introduce to you a very dynamic panel of providers who can talk to you about what they're doing in research and how they're engaging the community, probably something a little different from what you've had before. Our first presenter is Dr. Floyd Willis, who's a family physician at the Mayo Clinic in Jacksonville. He's got over 30 years of healthcare experience, but he's also a key investigator at the Mayo Clinic, engaging the communities in the Jacksonville area for Alzheimer's disease research at the Mayo Clinic ADRC. Our second presenter is Dr. Wang, who is a professor of genetics and vice chair of research at the University of Pennsylvania, who has worked with genomics and genetics in terms of better characterizing Alzheimer's and related dementias. And our final presenter is Dr. Ambar Koreshta, who is a family physician and epidemiologist here at Emory University, is jointly appointed in the Department of Family Medicine and the Department of Epidemiology. And his research focuses on cardiovascular disease and risk factors and lifestyle modifications that probably can be made to minimize one's risk for developing Alzheimer's and related dementias. At this time, I'd like to bring on Dr. Floyd Willis. Dr. Willis will be followed by Dr. Wang, and Dr. Ambar Koreshta will be our final presenter. Gentlemen.
It is my pleasure to be here with you, and I hope everyone can see the slides.
They look great.
Yeah, great. It's always an honor to speak with colleagues. It's always an honor to speak with anyone about this particular labor of love of trying to be sure that all of the fantastic work that we're doing on Alzheimer's research does not leave entire populations behind. I think we know what the problem is. Doesn't necessarily need to be restated. For the purposes of being clear, we have a paucity of people who are participating in clinical trials who are Black and brown. This number, about 8% of African Americans, and if you look to the right side of the slide, less than that, 5% with regard to memory loss and dementia-related research. Actually, the number may be lower. We focus on a number of efforts here in Jacksonville to try to determine, try to equalize the people that we have participating in clinical trials. We often break it down into a personal level, protocol level, and health system levels, and I won't go through all of that. I'd like to focus on the personal level, because as you see, this is where I believe the rubber hits the road, whether it be face-to-face research, whether it's remote research, whether it's digital research. The past experiences, the fear of quote unquote being a guinea pig, sometimes language and cultural barriers, is I think the first stepping stone. It's very interesting to understand that and understand what people are experiencing when they sometimes are reluctant to participate in biomedical research. So I'd like to go back to take a quick walk through history so that we are all reminded of particularly African Americans' interactions with the Western healthcare system. It's been going on for a very, very long time. It's a challenge to all of us, and it was particularly a challenge here in Jacksonville. And as I explore the path, the path that we walked here to try to combat the barriers, we'll start way back with what some, at least these two Harvard scholars, feel might have been the first interaction that Africans or African Americans might have had with the Western healthcare system. This was a slave ship doctor screening people to be sure that they were healthy enough to go through the Middle Passage. This was the second highest paid person on the slave ship, only outpaid by the captain. And this might be the first interaction. Fast forward to 17 and 1800s. This is a slave hospital, Natchez, Mississippi. The conundrum here was whether or not you put a slave in this particular entity to see if they could improve and get well, or do you just allow them to pass away and go purchase another slave? The famous or infamous J. Marion Sims, who operated on people as depicted in this photograph, repeatedly, it is reported, after purposely addicting them to heroin. You can see from this depiction that there are people on the left side of the screen peering around, because this was known throughout the community back in those days that this kind of work was going on. The eugenics, the movement that started in 1902 in Cold Springs Harbor, where more than 60,000 people were sterilized, many of whom were Black and African Americans, but poor whites were subjected to this as well. And this is as late as 2003, where people were still being apologized to for having these kinds of heinous things occur to them without knowledge of it. The famous Tuskegee experiment, which ended in the 70s. And the final slide, which I think is very pertinent to this particular group, is from a book that was given to me by my brother-in-law, who is a practicing dentist. He did his work, his schooling at the Medical College of Georgia in Augusta, Georgia. And it was around my father-in-law's kitchen table where we began to talk about the challenges I was having back then in recruiting African Americans to Mayo studies. My brother-in-law went to grab this book because it was on the Medical College of Georgia. It was written about the Medical College of Georgia, where apparently they were doing some renovation in his very dental school building. And what they found as they excavated the bottom, the basement of this particular building, was thousands and thousands of bones. To make a very long story short, these bones were categorized by anthropologists and found to be 90+% African American. And so what was happening at Medical College at this particular time is that people were robbing the graves of Blacks and poor whites. Not only that, but they would go throughout the neighborhood and knock on doors and ask, particularly those who are African American, please come with us to our school and we will make you better. Very often, they did not get better. It's just the part of history that sometimes we don't hear about, and that's not even the most remarkable part of this. At that very table in walks my 90+-year-old father-in-law, who said, "What are you talking about?" We told him. And he began to explain to us the name of the person who actually was charged with scouting the community to find those people who were sick, who would be taken to the Medical College of Georgia for these purposes. We asked him, had he read the book? He said, "No, I've heard the stories." People wound up securing the graves of their loved ones with concrete and steel to try to keep people from disturbing the graves. And that is just a quick example of the history that we need to be aware of when we are asking for people's time and treasure and their trust. And that is my whole point. The trust is extremely important. It cannot be understated as we talk about enlisting underrepresented minorities who have had this history with the United States healthcare system. So what did we do? We did what a lot of us do. As we were working on this particular study, we went to the Black church. We'd already been working in the Black church on some problems, and this was quite a large study. There was very minimal, if any, neuropsychological data on African Americans in the South. And we completed a relatively large study, recruiting them mostly through the Black church and mostly through the trust that the Black church already had in us and our team before this study came about. The faith-based wellness strategies really work with regard to recruitment. So we have tried to leverage that partnership, because the Black church is still the place where most or a lot of trusted information, health and otherwise, is disseminated in the Black community. It was the only place for hundreds of years. So we maintain great contact with them, and this is an example of a program called Pastors Heal Thyself. Pastors Heal Thyself, where we invite faith leaders to seminars and talk about everything from Alzheimer's disease to wellness. And our focus is to build trust with them, show them how to live healthier lives, and then hope that they will allow us to pass on not only this information to their constituents and parishioners, but maybe allow us to introduce clinical and biomedical research to them as well. 2005, we were very interested in recruiting to our memory disorder clinic here. We launched a campaign called Live Well, Think Well, Healthy Brain Aging. We were working to collect neuropsychological data, but also normative data on African Americans. This was a large study that blanketed the city, not only with print media, but our name was on the side of buses in town. And you can see large numbers of people were reached through television, radio, and print, and it worked quite nicely. That study is still, I think, one of the largest and longest running programs on normative data and African Americans in the country. You see that picture of me right in the corner. That was quite a few years ago, but I still fit that tie. I can still wear it. I'm not sure about the pants and the shirt, but the tie still works. Again, just an example of that particular effort. This illustrates before and after the implementation of that particular PR campaign that we just talked about. Very minimal people recruited for this MCI project, but after the campaign started, you can see the numbers rose, 18, 5, 6, 13. So it worked. We set up a community research advisory board, the CRAB. And as we were rolling out these studies, we went to them, and they were composed of community leaders. And when I say community leaders, I don't necessarily mean the presidents of the organizations in the communities, but those leaders who were the leadership on the blocks in the communities where we were working, regardless of their educational financial status. That has been going on for about 20 years. We meet with this group before a study is launched, while it's going on, and report back to them once we have completed the group. We have group discussions, and this is an illustration of a discussion that we had actually with local physicians. We gathered 20 to 30 of them to ask what they thought was important. This happens to be a cancer project, but the outreach strategy will work whether it's cancer or Alzheimer's disease. We work to try to make sure that we are innovative in our approaches. We have a hub downtown, the Florida American Leisure Post, that serves the underserved. It is our target population. And again, we do it to build trust, to continue to build trust in the community. We have a mobile unit, and as of tomorrow, we will be opening a downtown office, which will not see clinical patients. It is built just to connect with the community, offer them the opportunity to participate in a clinical trial if they choose so, without having to necessarily leave their community. This is the Northeast Florida Clinical Trials and Translational Science Consortium, composed of about 20 to 25 physicians, 90% of them primary care physicians. It is to connect with them and get them involved in clinical trial, because as Dr. Willis Parker said earlier, the trust is very important, and more often than we'd like to think, they have trust in their primary care physicians. And if the primary care physicians are interested in clinical trials, we believe this may translate into them being more interested, the patient being more interested in clinical trials as well. So we've just launched this recently and continuing to groom it. Again, continue to work on our innovative projects in technology, processes, enabling the visits, and we're including non-traditional things like pharmacists, helping to coach people through diseases, cancer and diabetes. I wanted to get through all of those slides, and I'm glad we were able to show the historical ones. Thank you very much for your time and attention. And I am going to turn it over to Dr. Wang.
Thank you, Dr. Willis.
Okay, thank you, Dr. Willis, and thank you, Dr. Parker. Thank you, NACC, for having me here. And I'm really glad to have this opportunity to share with you our project on recruiting Asian Americans. And some of you probably already heard about it at previous ADRC directors meetings. We continue to make progress. So this is going to be a short overview. So we start with the challenges in recruiting AAPIs. It's not some centers have been working on it and have great progress, but I think there's still like we need to do more as a whole, and it does have its unique challenges. Here are some of them. For example, where the communities are physically located, and sometimes they're not close to the Alzheimer's centers. The next challenge is language and culture, especially like when we talk about different groups, different Asian American groups, they have their own language and like the culture that will affect the way you collect and assess data as well. So you need something that's appropriate for the culture. There's also a lack of funding and active recruitment. It's not easy. It's a lot of work, and you need to continue to do that. And I'm really glad that our funding agency, NI, has been like ramping up the support, and we'll talk about it a little bit. And the last one is especially with all the minority communities, you need to build the trust, you need to build a connection with them. You need to support and let them understand this is we want to study, we want to learn your needs, and hope this will increase the health of the company as a whole. We're not just coming and take the data away and forget about you. So that requires, like, all these require long-term investment and people who are dedicated to the cause of the communities. It's fortunate that there are plenty in the Alzheimer research community who really believes in this, and we got together, work together on this. For the past 5 years, we've been planning this, and I'm really glad to report that we received the funding from NIA earlier, like maybe a few months ago, to support this study, ACAD. And this is an international study, including Canada. We have in a new grant, we're going to have 9 sites focusing on 3 Asian American populations at the beginning. And this is an MPI grant, and some of the other MPIs you probably know. They've been working in this area some longer than I am. Our goal is to recruit 5,000 participants in the next 5 years. We're focusing on Chinese and Korean, Vietnamese ancestry, but we do think that the procedures and the frameworks we introduced that at some point, depending on how much we can do, can extend to other populations as well. We take a community-based participatory research approach. We want to use culturally appropriate recruitment and assessment data collection. We're going to collect DNA for genetics, and we're also starting to collect plasma for blood-based biomarkers. I think that's one of the things that's really exciting about this study. We want to decide what is the best way for blood-based biomarker diagnosis for Alzheimer's for this population, which is probably going to be different from the other populations. I want to show this figure. These are people who we've worked together, some as early as 2018, including planning, looking at feasibilities, as well as a pilot phase. And some of these are leaders in this field who have a lot of experience working on other communities. Some have already been working on serving the Asian communities, and it wouldn't happen without these people. And the other I want to emphasize is we have like young investigators, assistant professors who are now really driving the science forward. And that, I think, is one of the most rewarding things for this project. We have developed a protocol that want to make sure it is compatible with especially NACC UDS, which is an industry standard. And we got a lot of help from NACC on how to do this, but in the meantime, want to focus on things that we can afford to do that's feasible, considering that sometimes you can't bring the participant to the clinic to do like more expensive assays. This is the protocol, and you'll see that a lot of things that you'll find really familiar with with the different instruments in NACC. And the whole process is really, like we leverage the experience that we learned from the Alzheimer's centers. We've started in 2021, and so it's been 2 years, and we continue to make steady progress. And this is a little bit outdated, but the number continue to go up, and we have a lot of people who are interested. So it's somehow also limited to our capacity on how we can enroll people interested. We can send them and do screening. One thing I do want to say is this is going to be a very exciting story. Data sets. Many of these are immigrants, so they will present a slightly different perspective in terms of live exposure. And you look at the level of education is really spread like a wide range that reflects this special population we're studying. So we're really excited about this. It also shows the approach we have for recruitment and engagement is really working. The project, the overall study also has a scientific components in addition to generating data, which will make it available to the research community. But we're also looking at genetics as well as other risk factors and their interactions for this data. And we also think that these data will, is going to contribute to science even more when we talk about collaboration with our other studies with our colleagues in Asia. That actually is an exciting opportunity to look at a natural experiment where if the genetic background is similar, but you have different life experiences, how does that affect the risk of Alzheimer's and so on? So the other thing is we're developing resources and protocols that including training materials, translation, and validation processes that will be available for other people who want to set up similar studies, and we can make sure that data are going to be comparable. We think there's going to be clinical impacts of our study, how we can better serve the Asian community. First is we're going to gain new insights on the neurodegeneration, the biology, and also therapeutic projects that might be more effective for the population we're serving. With all the data and the analysis, that also, especially with blood-based biomarkers, that also allow us to do earlier diagnosis and risk modeling to identify high-risk populations. We can hopefully, it would be great if we can develop some preventive measures that's more effective for the Asian lifestyle. And all of these will help us improve the clinical trial readiness for the Asians, which is one of the major goals we want to do. So that is my overview for the study. It's a really complex and big project, a lot of things going on. So in fact, I want to pitch this. Tomorrow, NI has a quarterly webinar that focuses on diversity, health disparities, and I'm going to talk about ACAD, but also the Alzheimer's sequencing project diversity initiative. So there's going to be more details, and I think we're going to put the link on the chat box, but just Google the event, and it requires advanced registration, but it's totally free. And I invite you to consider participating. That's going to show support to our study, which we'll really appreciate it. So thank you so much for your time. I'm going to pass it to the next speaker, Dr. Koshresta.
Thank you, Dr. Wang. Thank you very much. Dr. Koshresta.
Thank you, Dr. Wang. And thank you, Monica. I really appreciate everyone for inviting me to present some of our early work here at Emory. I'm, as I said, a primary care physician and also an early stage investigator, and this is a relatively new effort, so excited to present. So we are all excited about, precision medicine and to get to the right treatment for the right person at the right time. And the only way we can really do this is by increasing representation in clinical trials and research. So we all know this data well, that 40% American Americans identify as non-white, but represent 2 to 16% in clinical trials. And we all know this as well, that they had increased risk for ADRD and need to be more involved in studies for both recruitment as well as retention of participants. And this has been a national priority and is frequently now recognized as how much of time and expense it adds, but of the critical importance of this work. So again, to emphasize some of the points that Dr. Wang and Dr. Willis have made, that only when we increase the diversity of our studies can we really understand what are the differences in how different diagnostic as well as treatments can really work. We will be able to understand sometimes new protective factors or risk factors that are there in a population that can be driving ADRD in different population subgroups. It's important for study validity and generalization of guidelines that come out from organizations. And again, to make the same point that it's so important for participants of different subgroups to be involved in research to reduce disparities. And funding sources these days are requiring that you have a minority representation in all the studies that are being funded for. So what is a common barrier? There's always this frustration that there's inadequate budget for recruitment. And sometimes there's also this challenge that, we have a pretty superficial relationship with communities. So how can we do this better? How do we engage with community in a more long-term way, trying to understand their needs and their interests? There's also the participant mistrust and fear of being involved in anything called as research. And when we try to understand and enroll participants in research, we really have to understand where they're coming from. What are the barriers in terms of like childcare, transportation costs that may be posing a barrier for them to be spending 1 or 2 hours in a research study. And we already understand how much recruitment material needs to be culturally tailored. And as Dr. Wang mentioned, in terms of even language, and being able to connect with the research team well. And that brings us to another challenge: is how do we hire the right team for this job? How do we train them to understand the community they're trying to recruit, and also be able to understand their concerns and wants? So I want to talk about South Asian community. South Asians, they are considered in the Asian category, and in the US, they have increased to 3-fold in the past decades. And their current numbers stand at 5.4 million and one of the fastest growing ethnicities in the United States. Globally, they actually represent 2 billion people. These are the countries they represent. And interestingly, despite having one of the highest incomes and rates of education, they have poor health outcomes. In fact, South Asians frequently have 4 times the risk of heart disease and 6 times the risk of diabetes. So these are some of the vascular risk factors, which are also a driver for a lot of ADRD, is something these population are going to face soon. So, and when you hear of stories of a 65-year-old dad, for example, taking his son in an ambulance for an MI, these stories are unfortunately really common in South Asian community. So what can we do about this, and how do we understand aging and dementia in this population is critical, and we need to target our recruitment efforts that really tailor to the needs of this community. And when we look back in the literature, there's almost no studies in the US that have really addressed this in this population subgroup. There are current efforts, which I'm really excited about, but I think we need to do a lot more. So at Emory, we just started this program in this past year to really understand what South Asians feel about health and aging, and then to understand what they understand about dementia and how they would perceive participating in a research trial. So we surveyed 100 community participants to measure their attitudes regarding dementia research. And we don't hear that in literature or in scientific talk that often, but more than a third of these participants know someone with dementia and understand that it's a concerning disease. half mentioned that they actually feel that their behavior is perceived based on South Asian stereotypes, like, for example, vegetarian diet. And more than 40% have trouble understanding the medical conditions. So despite the high levels of education, there is a certain challenge in them trying to be able to connect with their healthcare community and take advantage of all the resources that are available. But I would like to actually also present some qualitative data, which is extremely helpful in when we try to recruit minority patients or underrepresented communities. So for example, these are some of the comments made when we were trying to administer these surveys. Is you frequently hear about, they say, I would consult with my family before participating. So there's a reliance on making decisions as a unit. Now, we emphasize research as, okay, it's your individual decision, but in these communities, it may be that a family decides for the participant. There's also the concern that research is driven by profit motives, and I'm being used as a guinea pig. So I think this is where we need to really ensure transparency and building that long-term trust that research is really for their own benefit and understanding how diseases and medications may work for them. And other points that were emphasized, it's more reassuring when study staff can communicate with me in my native language, something that Dr. Wang mentioned, that we need to develop tailored material and also make sure the study team is really recruited from these communities and are involved in all steps of the research. And again, the point I made about childcare and another thing, that any kind of a participation, we need to really center around the study participant and make sure it doesn't disrupt their routine, because they might be taking care of their elderly or their children. So I make the points, which is, I think all of us are well familiar with, that we need to really emphasize budget, because all of this takes staffing as well as really a focus on trying to make recruitment, which is a science in itself, to understand what works and what doesn't, and always perform feasibility assessment. So our study is really a feasibility to understand about dementia in this community. And again, we have to really engage and understand the community priorities before we emphasize our agenda to them, right? So it's a mutual partnership. And not only do we need to have clear recruitment, but also retention goals, because a one-time stop to conduct a survey is not going to really help engage any community. So I think the way we have thought about is that we really want to provide education on a long-term basis on topics that are of their interest. For example, diabetes. Now, we know that diabetes is also a risk factor for dementia, so we can link things up, but you really have to understand what are the current priorities of this community and what are the diseases that are really bothering them. And finally, that making sure our team has training in cultural humility as they connect with this with these population subgroups. We also have to understand that we minimize the participant burden. Now, I'm a researcher and I'm also a physician, and frequently my researcher hat on, I want to administer long surveys, multiple surveys. But as soon as I put my clinician hat on or a patient hat on, I feel like I really want to understand that any of these surveys, if they become too burdensome, participants are not going to complete them and they're not going to follow up them. So we really have to think about that aspect, that there are trade-offs involved. And as I mentioned, we need to collect both qualitative and quantitative data as we try to understand our patients and caregivers. And finally, as I mentioned, that we need to be transparent, so that's how we build trust with these communities. We share results back with them, which I think is a frequent point that has been made by communities, that researchers come, they administer surveys, and we never hear back from them. I think only when we make sure we have that connection back, that this is what their data yielded and this is what it means, will we really be able to establish long-term trust. And last, I would like to emphasize the role of primary care physicians. They are, beyond taking the help of community health workers and care navigator, which are critical to enrolling minority communities. The role of primary care physician is also very critical, because they are really the ones that see the most diverse patients. They already have ongoing relationship with patients and families. So the trust and rapport is there. And they also have that understanding of a holistic, like when we approach science in very strong silos, right? We think of dementia and we think of all the side effects of the drugs and everything from that aspect. But I think primary care physicians really have it to put any condition in a context of the patient overall health and well-being. And I think that really helps also gain patients and study participants confidence in the research that, yes, it will impact overall my health in a good way. And finally, for care coordination and all, primary care physicians remain really critical because they are the ones who are following these participants long-term for monitoring for side effects and other things. And of course, as we mentioned, their role in screening and early detection cannot be emphasized enough for that. So with that, I would like to thank our ADRC over here and the Community Advisory Board and participants who's helping me launch this effort. So thank you very much and look forward to more questions.
Thank you, Dr. Kulreshta. At this time, I do see a few questions that are in the chat box. And for those of us who've just concluded the presentations, if you have a question for any of our presenters, kindly put them in the chat box and we'll address them accordingly. A couple of common themes, regardless of the ethnicity, that I think that have come across are, number one, we need to be transparent with respect to what it is we want from these communities of color. Things that are important to these communities is that they have providers and research are approached by people with whom they have ethnic congruence, whether that's a provider who looks like them, somebody who can communicate with them in their language. And lastly, and this is the part that I think is really important, understanding what their medical needs are and how those things need to be addressed before you start asking for research. I think this is something that many of us intuitively know, but sometimes it's important to restate it. You can't just shove a coordinator into a community and say, I want you to join my study, and not have had a relationship with them. There are a couple of things that I found very interesting, and I wanted to ask Dr. Wang, with respect to the Asian AAPI cohort that you're working with. Looking at your map, you have a number of different Asian communities that you're interfacing with. I saw Chinese, I saw Japanese, I saw Vietnamese, but in your algorithm, part of what you're doing with the research is you're not getting biospecimens, so you're not doing lumbar punctures and things like that, right?
No, but yes. It's possible. We collaborate with many Alzheimer's research centers, so sometimes they could be co-enrolled into like centers and where they collect additional data or samples. But we're not doing it because two reasons. One is we're not so sure if it's like there's more concerns, especially from this community, about whether they feel comfortable with lumbar puncture. And the second is many of these recruitments, we need to go to the community or even do remote assessment because of the locations. They're not close to the Alzheimer's Center. So we try to do things consistently on all the sites on the things that we definitely know we can do. Lumbar puncture is a little bit more challenging.
So when you're recruiting these persons, are you using physicians or healthcare organizations in AAPI communities? Where are you getting people from?
Yes. That's actually the biggest challenge for this study. How do you engage the communities? And our approach is for the sites we identify that are collaborating with us, every site comes with their own strategy about how to reach out. They already have the connection. Some of them is through, like nursing homes, or they have connections to the communities, through the clinics, and some of them have the healthcare system, especially our like the sites in Canada. That has been how they're reaching out to get referrals. But I think you need to actively recruit them, and it's going to be harder if you're just like waiting there for them to participate because of this community.
So on that note, Dr. Kulreshta and all three of you really, Dr. Willis talked about mistrust, medical mistrust in the African-American community in the Deep South. What are some of the mistrust issues in the AAPI and Southeast Asian community with larger medical institutions? That's one of the questions that's in the chat. Are there medical mistrust issues in the AAPI and Southeast Asian community?
Well, I think there is, but unfortunately, I'm not an expert on this. But we have teams that have been dedicated to the the health disparity issue in this community. So I'm not the best person to answer it. I do think that one of the concerns we have is like what Dr. Koreshta mentioned earlier is you take their data and samples don't get back to us, but and we want to help, but also there are some. I think when we think about return data to the participants, you got to make sure that you're doing a way that we have the capacity to do. If we give them data, we need to make sure they're properly like interpreted. For Alzheimer's Center, it's probably more feasible because you already have physicians that are doing the data assessment can be done. And for some of the sites we're doing, that's going to be more difficult. So a lot of the data we collect, you don't need a physician to do, and you can have a trained healthcare professionals like nurses that can do some of the data collection. So we try to like for genetic substitution is important. We want a big sample size so there's statistical power, but that also means that there are certain things we can't afford to do. One of them is like return comprehensive results. Actually, I see that Dr. Gary Peavy is here. I don't know if you have any other thing you want to add. Dr. Peavy is the core lead of our training core, and also she's the lead of the recruitment side at UCSD. Sorry, you're on mute. Gary, on your mute.
If she can put it in the chat, that may work. While we're working on that, there she is. Dr. Peavy.
No, I was just going to say that Lisana's covered it very well. And, we're covering as many aspects of our populations as we can, and thinking of very creative ideas actually for recruitment, including advisory boards and, community partners. And we're also for UCSD, we're partnering with UC Irvine too, because there's so many Vietnamese in that area. So different creative solutions.
Dr. Koreshta.
Yes, I would definitely like to add, we have to recognize the heterogeneity that exists in these community, and that what is working for African American, Black communities and Far East Asian communities may not work.
I think he'll come back, but I think what he was trying to say is there's heterogeneity in all of these groups, and what works for African Americans may not work for AAPI, may not work for Southeast Asians as well. So it is not a one size fits all. And for that purpose, Dr. Willis, you have in Jacksonville not only African Americans, but you have other groups. So how does the ADRC interface with those different groups that are in the Jacksonville community?
The ADRC, I think, they put forth similar efforts that we do with the African Americans. The large population of Hispanics here, I think, are approached in much the same way. Interestingly, the Black church has been very, very helpful in our recruitment processes. And at least one of my colleagues here, both in memory loss studies and cancer studies, utilizes the significant number of Hispanic-based churches here and the leadership that provides for the community to recruit to these studies. And of course, outreach and education. It's hard to understate, I think, the influence that you can have when you are legitimately coming to the community with interesting information to try to explain why these disease processes may disproportionately affect them. It not only helps to educate us all, but I really believe it bridges some of that distrust. And that's what they do with a number of the Hispanic efforts to recruit Hispanics. And we certainly continue to do that with African Americans.
I'm not sure where Ambar is, but we're waiting.
I'm here. I'm back. Sorry, I had
Thank you.
a connection issue with my internet. Sorry. So I think the point I was trying to make is that I think with the trust issue, there's a lot of concern among South Asians that we frequently talk to, is that a lot of this is driven by pharma industry or profit motives. And I think that's the key thing that I keep hearing again and again. And I feel like the best way we can, make them understand about the importance of research is to do it very slowly. And, in the sense that, start building their comfort level and confidence level by doing surveys and then involving them in studies that don't involve too much of, interventions. And gradually, when they see how this is benefiting and show them back the results, the point I made before is how we're going to, be able to succeed in this effort.
Thank you. There is a question in the chat from Leanne Mandarino from Cleveland. Do you have any advice on reaching the busy PCP and getting them interested in and referring people to clinical trials? As one of those busy PCPs, I couldn't get involved in research if I didn't know about it. So if I don't know that there's an opportunity to refer patients to a study, I can't refer them. So partnering with and having updates with primary care providers to make them aware of opportunities that may be of value to their patients is important. I got into research primarily because my geriatric care clinic was next to the neurologist, and I kept watching what they were doing, and I tried to understand how they got that done. And that's how I got interested. But if I hadn't been working with Jim Law and Alan Levy, I wouldn't have known that there was an opportunity to participate in research. So one of the things I used to do is plot research coordinators in the lobby on certain days that I was there so they could pass out their information and talk about the studies. But I usually talk to the patients first and let them talk to the coordinator later. But I think that it is important for you to look at the network of providers that you're working with and to involve them in the enterprise. I think it's a mistake to send coordinators into communities where there's not been any prepping and there's not been any buy-in, not only from the providers, but from the patient population. They don't know them. They don't have any relationship with them. I see there's more questions, and there are other things about engaging primary care doctors, but you're talking to 3 of them, and all of us have a little different story about how we got engaged in research. And I would have to say that our reputations and our patient populations have been leveraged to improve recruitment. And again, outside of academic medical centers, providers are interested, but they can't help you recruit if they don't know about it. So make a friend. At this time, it's 12:54. So I'm going to turn this part of the program back over to Dr. Wang. Thank you all for joining us today, Dr. Willis, Dr. Wang, and Dr. Kulreska. We look forward to hearing more from you. Please sign up for Dr. Wang's webinar tomorrow, NIH-sponsored webinar, to learn more about the AAPI outreach that we're doing. Dr. Wang?
Well, I want to thank everyone for a really exciting webinar. I think we've only really begun to sort of touch the tip of the iceberg of the really important work that needs to be done. And I think recruitment is sort of the endpoint, right, of an evolution process. I think one of the really key things that came up was return of results, right? What are people expecting? What's clinically actionable as opposed to, say, research still in development? And I think that's a key area of where outreach cores can start to begin to talk with other cores. And I think that would be a really important opportunity. I think the other key thing that was mentioned that we didn't have a chance to get into, though, is also the concerns about digital equity. And I hope that may be brought up in a future webinar. I really hope that everyone is registered or registering for the NACC fall meeting. Hannah's going to be dropping in that link in the chat. We hope you'll join us either in person or in San Diego or online. We'd really love to continue the conversation during our ORCOR meeting, which is titled Ideas to Implementation. And Monica will be leading a really exciting discussion with another set of panelists from other ADRCs to discuss this. We're also going to touch on another key issue about connecting to bilingual and multilingual communities. Dr. Miguel Arce from the Columbia ADRC is going to be raising conversations on what we can be doing to also incorporate outreach and recruitment for these communities as well, especially as we roll out the new version of UDS that contains the Spanish and Chinese versions for cognitive testing and assessment. So I think without further ado, I want to hand it back to NACC for Hannah for a few other housekeeping items. And if you didn't register for Dr. Wang's webinar for NIA, hopefully you can catch that. But I think Hannah also put that in the chat as well. So stay in touch and we will hopefully see all of you in San Diego, either in person or virtually.
Yeah, I just want to give a big thanks to all of our speakers today and Monica for organizing this wonderful webinar. I am popping a link in the chat for registering for the ADRC meeting. And we're really excited to see you all there. We'll follow up with our speakers today to see if any are willing to share slides, and we'll send that out to everyone who had registered if those slides are available. But until then, see you in October.